There's a lot to discuss today, and we have a fantastic panel to help us navigate through it all. A few notes before we begin. The event is being recorded, and soon afterwards it will be available on our school's website, the UCLA Fielding School website, and also on our school's YouTube channel. We've already received many questions from the audience, and additionally, our Zoom audience, feel free to submit questions on the Q&A button on your screen, and we'll include questions throughout our conversations today from the audience and hope to get through as many as we can. It's now my pleasure to introduce our terrific panelists. Dr. Robert Kim-Farley is UCLA Professor of Epidemiology and Community Health Sciences here at the Fielding School. He has served as Director of the Division of Communicable Disease Control and Prevention at the Los Angeles County Department of Public Health. He's board certified in preventive medicine, and he works to address preparedness for public health and to control and reduce and eradicate communicable diseases. He has previously had significant roles at the U.S. Centers for Disease Control and the World Health Organization, where he's worked with many countries throughout the world. Also joining us today is Dr. Anne Rimoin. Dr. Rimoin is UCLA Professor of Epidemiology and the inaugural Gordon Levin Chair in Infectious Diseases and Public Health. She also directs our school's Center for Global and Immigrant Health and is an expert in emerging infectious diseases. She is the founder of the UCLA DRC Health Research and Training Program in the Democratic Republic of the Congo. And here in Los Angeles, she serves as co-principal investigator for the UCLA COVID-19 Rapid Response Initiative. And now, please join me in welcoming Dr. Robert Kim-Farley and Dr. Anne Rimoin. Welcome, it's great to see you.
Pleasure to be with you.
Thanks
Terrific.
for having me.
I'm delighted you're able to join us. Lot to unpack today. Bob, let me start with you. Many schools are back in session across the United States. Do you have concerns? And if you do, what should we be doing to address them?
I think the biggest concern is the recognition that the rates of disease in schools is going to mirror the rates of disease in the communities around them. And unfortunately, with the Delta variant, we are seeing rising rates in many areas. So this is going to translate into potential outbreaks, and some we've already seen in schools. So that it's going to be important that school districts try to implement the methods to be able to reduce and prevent COVID circulation. And we'll talk about that later. But I think that we're really at a crossroads here, and the patchwork that we see across the United States, where some school districts even have banned use of masks, is a really problematic for public health.
Yeah. And we're hearing that LA may mandate vaccines for students over 12 who are attending class in person. What do you think about that?
I think that LAUSD has been leading the battle here against COVID-19. They were the first to mandate testing for everybody, not just unvaccinated individuals, which I think is a very, very strong policy. And I think that this policy requiring vaccination for everyone that is eligible for it is going to be critical in terms of reducing the potential for spread of the virus. As Dr. Kim-Farley just said, we have a variant that's circulating that is so much more contagious than the original variant, than what we were dealing with last year. That we really have to be putting all of the things that we can into play. And so I'm very supportive of LAUSD's move. But I have to also point out that I don't think it's just about, I think that that's one strategy that's going to be important. It's not the only strategy. We're going to have to require vaccination. We're also going to have to require testing because we know that there are breakthrough cases that occur. And then we're also going to have to be continuing to use social distancing, ventilation, and all of the other measures that we know how to use.
So let's, you brought up the issue of testing, and breakthrough infections are, everyone now seems to know someone or somebody who's had a breakthrough infection. Should we be testing vaccinated teachers, staff, and older students who've already been vaccinated? And how frequently should we be testing? Bob, do you have a view on that?
Yes, I think ideally we do test regularly. And I think that that's one thing, again, LAUSD has done, which leads the nation in terms of this sort of a mandate in place. But that's the only way we as epidemiologists can know what the pulse is in the community and in our schools, is to be able to have frequent testing of both vaccinated as well as unvaccinated. Because
both vaccinated and unvaccinated.
As Ann just mentioned, is that that's a problem with the breakthrough infections that we are seeing.
Right. We're hearing, we're looking at an LA mandate for students over the age of 12. But there was an audience question that came in about elementary school students and what are effective ways to mitigate COVID risk for elementary school students right now. Ann, you want to take that one?
Sure. Well, I think it's really important to remember that we have a lot of tools in our toolbox right now, and we have to be using all of them. The first of which is vaccination for people who are eligible. Now, who's eligible for elementary school? It's all of the teachers, all of the staff members, everybody around them. If we can get as many people vaccinated around these kids, we're going to be doing a better job of keeping the virus away from them. Now, that said, the other things that we can be doing is we can be testing, and we can be testing frequently. I think that the testing is going to be key because you need to be able to identify cases early on and be able to pull people out, isolate those who are sick, but then also quarantine those who are in close contact. It's important to remember that it's not just about that child, but all of the contacts of that child. And one of the complications of children in school is also there are often siblings involved, and siblings of a variety of different ages. And so it becomes very complicated. Of course, the other things, and these are all the things that we talked about before, we need to have good ventilation. I think that the issue of ventilation has been under discussed in these scenarios. And some of it is because a lot of these schools have trouble being able to update their buildings and being able to get this in place. But there are ways physically that we can do it with air scrubbers, with opening windows, with really reducing the occupancy wherever possible. And here in Los Angeles, and I always like to bring up this point that was brought up to me by one of our former students here in the epi department, which is that, during the 1918 pandemic, they held school outside in Los Angeles. And I think that we underuse the outdoors here in Los Angeles, and that we should really be thinking about that. And I'm gonna
absolutely. And we're fortunate that here in LA that we can do a lot outdoors.
Right.
Bob,
and you can also add on to what Dr. Rimoin is mentioning too, the idea of cohorting students to try to avoid mixing among classrooms and among grades. That's another way, so that if you do have a situation where COVID's introduced, it's not going to be, again, exposing as many people if we can kind of keep that contained, so that you can have a much smaller quarantined group than suddenly having to quarantine the whole school.
And that's what all the models show. It's all about mixing. And when you have that mixing, that's what propagates these epidemics. Exactly. Bob, I want to follow up a little bit more about the kids under 12. When do you think we're going to have a vaccine for children under 12? And do you have any concerns about, if we do get a vaccine approved for children under 12, about vaccinating young kids?
Yeah, so I think that's really going to be important for us. I mean, we're not going to reach levels of community immunity until we get children under 12 vaccinated. And I think that, the studies are being finalized. Pfizer especially is probably ahead of the game at the moment in terms of getting vaccines to at least emergency use authorization by the FDA. I expect that we will see that before the end of the year, and I hope sooner than later. And I don't have concerns because of the fact that we have such rigor of scientific study and controlled trials that are done here in the United States, that these vaccines, when they've been through this process, will be safe and effective. Admittedly, no vaccine is ever perfectly safe or perfectly effective, but I would not have concerns. And certainly it's going to be the same situation as we have with adults, that any concerns about side effects of vaccination are far outweighed by the true risks of severe disease and even death due to the disease itself.
And do you agree?
I absolutely agree with Dr. Kim-Farley. I think that we have to just really remember what the data is showing us and follow the science. So I'm totally in agreement with Dr. Kim-Farley.
Right. The Delta variant. Wow. I mean, that's squeezed everything out right now. Bob, can you give us a basic 101 class on how the Delta variant is different from the original virus we had?
Yeah, and maybe stepping back at the 35,000-foot view about these variants itself, actually there's three different categories of variants. You've got variants of interest that then become variants of concern, and you have variants of high consequence. So for example, we have a new variant out, Mu, we'll probably talk about that a little bit later, but it's now a variant of interest, and it has potential to be maybe more transmissible or more severe, et cetera. We just don't know yet. We need to study it more. You have then a variant of concern, which is what you just mentioned, Dean Brookmeyer, about, for example, the Delta variant is considered that. We know that it has more transmissibility, for example. We know that we are seeing more breakthrough infections. So that is why it is of concern to us. There is also that third category, a variant of high consequence. We actually don't have yet a variant that's in that category. But what that category would be is that basically our vaccines then actually become ineffective. And if we have a situation like that, that really is, again, the three-alarm fire, where we have to make sure that we're changing our vaccine formulations and going back to a lot more severe restrictions, because basically it means that our vaccines are not as effective. So in terms of your original question, the variant of concern that we're dealing with mostly now is the Delta variant. And why it's of concern is because we do know it's more transmissible. There's probably 1,000-fold more virus in the nose, for example, of someone who is vaccinated or unvaccinated with the Delta variant, which means, therefore, it is much more easy to be transmitted. And I think that prior to Delta, we felt that our vaccine was very good for not only prevention of severe disease or death, but also was fairly effective in stopping transmission, at least curbing it. However, with the Delta variant, it is really escaping our vaccine to actually have some significant breakthrough transmission occurring. And this then is going to throw off our concepts of community immunity or herd immunity, because the fact that the vaccine really isn't a brick wall to stop transmission. But again, perhaps further in the program, we can talk about the issues of community immunity.
Great. We do have a question from the audience back on the schools. What are the best practices to mitigate transmission at school? If a child shows COVID symptoms but not confirmed yet, should all siblings of the child be kept at home until the case is confirmed or ruled out?
So I'm happy to answer that one. And I think that it really depends upon, so first of all, if somebody is showing symptoms of COVID-19, it's wise to hold the child home until they have been either cleared or or confirmed as a case of COVID-19. Of course, we have to remember that no test is perfect, and it may or may not be completely accurate. We have issues of sensitivity, specificity. However, when a child is symptomatic, they're more likely to have an accurate test. So that's no matter what it is, whether it's an antigen test, a PCR test, a lamp test, all the same. The question, so that child should be isolated at home, should be tested, and if the child is positive, then they should follow those guidelines, which require at least 10 days of isolation. And then if their symptoms are starting to resolve, and there are no fever reducing medications required at that point. So following those CDC guidelines. In terms of the contacts, so other children in that household, it's very wise to test everybody else in that household to determine if they potentially also have COVID-19, whether or not you hold everybody home or whether you can hold everybody home is a different issue of logistics and your risk threshold. So depending upon what that risk threshold is, it's very important. Now, what I would say is that if that child tests positive, then everybody in that household should be considered exposed. And regardless of what the current guidelines are, I recommend that they quarantine appropriately, because we do know whether or not you are vaccinated, you are still at risk for getting this. And I've seen some preliminary data that suggests that household attack rates are similar between vaccinated and unvaccinated households or mixed households. I think it's really important that these guidelines be reconsidered as soon as possible, because if people can transmit the virus to vaccinated individuals, we really need to think about this.
And I agree that especially once the virus is in the household, you can expect with this transmissibility, virtually everybody in the household will become infected if they have not already been or are not vaccinated.
Right, vaccinated or not, yeah.
Yeah. So Bob, on the Delta, it's more infectious. First question I have is it as infectious if you're vaccinated compared to if you're unvaccinated? Is there a greater efficiency of transmission for unvaccinated compared to vaccinated, or is it about the same?
Well, interestingly enough, again, this viral load in the vaccinated and the unvaccinated appears to be about the same. So it may very well be that we're not seeing much diminution of transmission through breakthrough infections.
And that's on the transmission infectivity side. What about the severity of disease? Is there evidence that Delta causes more severe disease or less severe, or we don't know yet?
Bob, do you want to handle that? I can handle it. It doesn't matter.
Go ahead.
Okay. Well, I'll start, and then you can keep
Sounds
going.
Good.
So it's my understanding that there have been studies that, certainly what we're seeing is that this virus is significantly more transmissible. It's the estimates are very clear on that. And so you're going to see more people infected, and therefore it may appear that there's more severe disease. Although I have read some reports that Delta may actually also be responsible for more severe disease. So I'm not quite sure about the literature on that. But even just by being more transmissible, you're going to see a higher rate of hospitalization and death because it's going to be affecting more people.
Yeah, and I think the reality is that, fortunately, again, our current vaccines are holding up well for protection against severe disease and death. Basically, the people that are in the hospital and the people that are dying are primarily the unvaccinated. This is becoming much more, if you will, a pandemic among the unvaccinated.
And just to amplify what you're saying, Bob, I think it's also important to remember, so these vaccines, even with these breakthrough cases that we're seeing breakthrough cases becoming common, but they're often either asymptomatic or very mildly symptomatic. And when you do see people who are affected by it in a more severe manner, they're usually people who have underlying conditions or who are older. That's the first piece. But the second piece is that I do still think that these vaccines are providing some measure of protection against infection. It's not that they're not providing any measure of protection of infection. And I think that the statistics that I've most recently seen are something like, you're 5 times less likely to get COVID if you're vaccinated versus unvaccinated in a kind of a general term. But I'm not really sure. I think that some of that will depend upon what the kind of exposures that people are having, the context, where and how of it will probably have a bigger indication, which is why, Bob, is to your point, people in households, if they end up with somebody in the household who tests positive, whether they're vaccinated or not, eventually they probably end up getting it.
Yeah.
So.
And the real take-home message, I think, again, for our audience today, is that as much as they may be hearing the noise out there about the vaccine, well, maybe it's not as effective and things like this, the bottom line take-home message is, again, these vaccines are still highly effective for severe disease and death. And that's really what we want a vaccine to do, is protect against these severe events. So it is important to get vaccinated and to encourage people to get vaccinated, because this is what actually is going to save lives and help us get away from this fourth surge that we now find ourselves in nationwide.
I think that there's also some data to suggest that people who are vaccinated are potentially seeing, while they do have equal numbers of CT values at a certain point, that I think that they become that their infectious period might be diminished by being
rapidly drops off. Yes, I think you're correct.
So what we're looking at now is, possibly some new variants on the horizon. We're hearing about the mu variant and so forth. What do we know about these new variants? Are they going to eventually crowd out the Delta variant? And bottom line is, will our current vaccines work against them?
Well, the first piece of that are these new variants. I've been asked this a lot lately in a variety of different settings. Is what do we think about, for example, the mu variant? And what we think is that, certainly it's concerning that these vaccines may be able to evade the immune response better than potentially the Delta variant, but it doesn't seem to be more transmissible than the Delta variant right now. And so in terms of becoming the dominant variant, the variant that is more transmissible is more likely to be the dominant variant. And that, even if some of these other variants have features such as a diminished effectiveness against vaccine-induced immunity, there's no indication that they're going to become the dominant variant. But this is the reason why sequencing is so critical, that surveillance is so critical, that we need to be testing in any setting that we can have testing happen. I think that schools and universities are key areas for this, because that's a great population to be surveying and very, very clear. And so I think that it's going to be very, very important to be considering this over time.
And I think, in a sense, you can almost look at this. I think of it as a Darwinian evolution. What is it to the virus's benefit in terms of mutation? It's going to be more beneficial for it to survive and thrive if it can become more transmissible. So that's one thing we do seem to be seeing with some of these variants. And but it's not necessarily evolutionarily beneficial to become more severe, because obviously if it kills you, you're not going to be a source of transmission to others. So I expect that these will continue to mutate towards further transmissibility, but not necessarily towards further mortality rates.
Does it come down to a race at this point, a race in terms of getting people vaccinated to stop this constant evolution of the virus, so that it gets into a superior position where it can dominate?
Yeah, that's a very good point, because I think, oftentimes some people have had the vaccine hesitancy or even resistance by saying, well, look, I don't think my risk is that great. We need to somehow impart on people the importance of being good citizens, in the sense of getting vaccinated to help stop the circulation of viruses, to help stop the mutations that are occurring when you have such rampant multiplication going on and transmission going on. So, there really is an aspect of helping others and helping your society by becoming vaccinated yourself, whether you think you have a risk to yourself or not.
So here we are now at a key question. And you mentioned the idea of good citizenship. It comes down to getting vaccinated, and there's so much vaccine hesitancy. And we all probably know someone or know someone who knows someone who has not gotten the vaccine. How do we convince people to get vaccinated? How do we put this out there and explain what the issues and what's at stake? Bob, do you want to start on that one?
Okay, sure. I think, and again, Dr. Rimoin may have some thoughts on this as well. I think that, we do a fairly decent job, perhaps, in public health of putting out statistics showing TAC rates, vaccinated and unvaccinated and things like this. But, you know, the anti-vaccination movements often appeal much more to a non-linear, non-scientific view and much more on the emotional level. I think that we need to, in a sense, fight fire with fire, in the sense that you will see, and you're starting to see this a little bit on the news, where people who did not get vaccinated have either, you know, gotten very seriously ill themselves, or had a family member get very seriously ill or even die, and them expressing the regret of not having been vaccinated, of not having taken this seriously, of somehow not feeling it could affect them. The more stories we can get out that way, I think will help our public health approach to be able to also appeal to the emotional side of why do we want people to get vaccinated.
Anne, did you want to add to
Yeah,
that?
I think that, you know, I mean, I think Bob and I have both spent our careers working on immunization in a variety of different settings. And the first thing I would say is that there's no one size fits all plan here. And that, you know, some of this is political, some of this is cultural, some of this is misinformation, some of this is, you know, related to access to care or time to be able to make something happen. Some of this is just, you know, the people have been just in a wait and see mode, and that people are not necessarily vaccine. You know, they're not resistant to getting vaccines. They just really want to see how it plays out first. And oftentimes we you know, it's very hard to be able to put people all into the same bucket here. So I think that we have to be, we need to be approaching this in a variety of different ways, and really be listening to the communities who don't want to get vaccinated, and really understanding their perspective, and then providing opportunities to be able to ask questions, to be able to get them answered, and to be okay with people disagreeing. I think that we in public health are used to being able to come in and lead with science and to kind of discuss things, and not be in the you know, a situation where we're being asked questions and then somebody might challenge you. It's okay. I think that we need to invite these kinds of conversations, to be able to be willing to talk to people, to be able to explain what we know, what we don't know, what you know, and the reasons that we're choosing to get vaccinated. And if you can convince a few people in a community, in particular, you know, people that are influencers in those communities, I think that you know, that definitely goes a long way. But you have to be willing to be in it for the long haul. And just because you don't get people to decide to get vaccinated today doesn't mean that the same conversation, or a nuanced conversation, or a new conversation tomorrow can't be helpful. But I think you know, approaching it with understanding, with compassion, and respecting other people's viewpoints is critical in all of this. And then making these vaccines as easily accessible as possible. You can't have people have to struggle or have to deal with it outside of work, or if people have children that they're, you know, childcare issues or work issues, not being able, you have to bring the vaccines to people so it becomes very easy.
And Dr. Rimoin mentioned it briefly, but I think she's brought a very good point about the importance of having community influencers, community leaders, faith leaders, these folks to be able to have good discussions with public health, to be able to understand the issues, and then be able to present the rationale for vaccination to their congregation or to their followers, and they will be respected, they will be understood. And I think that may be much more than a talking head of public health, to have these leaders speaking out.
We're talking about getting people vaccinated. There is an audience question here. Should we be prioritizing more getting the unvaccinated vaccinated, or getting those folks who are already vaccinated their booster?
Well, I think that the first answer is right now, you know, we keep talking about the fact that the unvaccinated are really driving this pandemic. They're the most likely to become infected. They're more likely to suffer the consequences of it. And so there's a real need to get people vaccinated because they have no protection. So getting people vaccinated is, of course, priority number one. But we all know that as time goes on, and if we do really see this issue of waning immunity, we're going to have to prioritize boosters as well. And so we have to be thinking about what our goal is. If our goal, you know, our goals are to save lives, and that means that we need our elderly, and people who, people who may have waning immunity, who may end up being hospitalized, they need to be vaccinated. But we also really need to get all of these populations vaccinated who have not yet gotten that vaccine. Those people are at the greatest risk of not only being infected, of being hospitalized, of dying, of having long COVID. They are going to bear the most serious consequences. So I think that, it's not going to be an either or. We're going to have to multitask. But if we had to only pick one, of course, getting the unvaccinated vaccinated. That also is not just for our own communities here in the United States, but globally. Because as I always say, an infection anywhere is potentially an infection anywhere. And that's true for a variant of COVID-19. If we really want to be able to get people protected, and we want to prevent future variants from circulating, we're going to have to really think not only about our own communities, not our communities nationally, but globally.
Yeah.
I think that really is an ethical issue about the issue of, when you have vaccine and limited vaccine in the world community, to make sure that the most vulnerable around the world have access to this is very, very important, not only, again, for their own protection, but ultimately, as Dr. Moin's mentioning too, to help reduce the spread of variants that can come right back and bite us too. So I think that it's to our self-interest to make sure that we are working hard to vaccinate the world community.
Yeah. Let me Bob, let me ask you about boosters. First, just some basic information, if you could tell us, is the booster shot the same formulation as the first 2 doses? And should it be, or does it need to be different if we've got some new variants? And what are they going to work? What do we know about them?
Yeah, so there's been work being done by Pfizer on booster doses as well as Moderna, but the Pfizer information has gotten out first, and it's definitely showing that there is a benefit to having a booster. It looks like about after 8 months is a good timing, and that's what's going to be being recommended here in the United States, so that you can really increase these titers like tenfold more for protection. It doesn't necessarily, antibody titers or level of antibody doesn't necessarily correlate exactly with protection. There are other factors, other cellular immunity factors at work here. But we do see that there is some waning immunity. It's good then that we are doing boosters. I think ideally, the formulation of boosters would take into account the new Delta variant. And, to have had not only a booster, but a tweaked booster. But I have a sense that what's happening here is that Pfizer realizes that they would have to, jump through a lot of hoops again if they actually change their formulation, and then have to, perhaps do a lot more of the studies to be able to get that formulation approved. So at the moment, it does look like that the vaccine does well against like the Delta variant, and once boosted, does even better against the variant. But ideally, we will see, I think, in the future, especially as we see more variants arise, especially variants that start to outwit our vaccine, changes in formulations of boosters in the future.
And I was wondering what your take is on a lot of the evidence right now about boosters and the timing of things. We've been hearing 8 months in terms of since get a booster since your last dose, but I've also seen some Israeli data suggesting 5 months. Where are we on this, and how much do we really know about, what's the optimal timing for boosters?
Well, I think that there's still not enough data to truly understand it, and I think that we're looking at some of this. This is an emerging science. We're still trying to wrap our arms around all of this. I have some questions about how much of this is really related to waning immunity to the vaccines that we currently have versus insufficient immunity to these new variants like the Delta variant. Because I've seen breakthrough cases in people who were vaccinated in May, as opposed to, so I don't think it's necessarily just an issue, of just that we're starting to see waning immunity. I mean, I think that data is clear that there is some waning immunity starting somewhere between 5 and 8 months. And that goes back to this issue that has been coming up recently, that most vaccines that we have, in particular, vaccines against viruses, are multi-dose vaccines We can have dose 1 at, time 0, dose 2 somewhere around 30 to 60 days, and then a third dose somewhere around 6 months after that will produce this kind of long lasting immunity. And I think that this has been, discussed quite a bit recently, that, we had a reason for spacing these doses 3 and 4 weeks apart, which was because we were having tsunami of cases here and hospitalizations and death. And we needed to get a lot of, have immunity as quickly as we possibly could. So we were playing the short game to be able to get people, neutralizing antibodies as quickly as possible to fight what was right in front of us. But in terms of playing the long game now, I think we really are going to need a third dose, which really actually is not a booster.
Let's talk about that third dose. And do you have any concerns? We're talking about, waning immunity, and there is some data out there about waning immunity. A couple months from now, a lot of us have been vaccinated, will be out 5, 8 months or more. If we don't get boosters, are you worried of yet another wave, or what is about to happen if the boosters don't get out? Bob, you want to start on that one?
Well, I think it's still a little too soon to know, how far down this waning immunity can actually then start impacting severe disease and death. Certainly the idea of breakthrough infections, I think, will become more frequent. But I think that, again, there are other factors. There's also what we call anamnestic response, that even if you have low levels of antibody, if you're confronted and exposed with the wild virus, again, you would have a very quick response, mounted response. So even though your detectable antibodies have waned, you actually still may have good protection for severe disease and death. So some of these things I think we'll find out over time as we see people who have had the second dose of vaccine, and it's been 8 months, year, et cetera, to see how they actually respond again to severe disease and death. But I wouldn't be surprised if they still hold up pretty well for those more severe consequences.
And there's an audience question here. Do you have any concerns about mixing vaccines for a booster shot or a third dose? If you had, for example, Moderna and then taking Pfizer, what's your take on that?
Well, so I just want to say that I agree with Bob's point, and I think that the last thing that we have to think about is, are we trying to prevent infection, or are we trying to prevent hospitalization and death? And then what are the cost benefits to all of this? So I think there's like a bigger issue to be even discussed there. I think that this question about mixing and matching of vaccines, the short answer is we're still looking at the data. But there have been some studies, notably in the UK, looking at the use of AstraZeneca vaccine as the primary dose, and then a mRNA vaccine as a boosting dose, and that is showing not only great safety, but also efficacy in terms of creating quite a good immune response. But I think that the question where people are asking, well, should I, could I, can I think that the likely answer is going to be, probably yes. And I think it's also great to see those data as opposed to taking it upon ourselves to be experimenting, because I think that there are also just some issues in terms of really understanding what long-term effects are going to be, how well it's going to last, and the mixing and matching may have some benefits, or the benefits may be incremental and not enough to outweigh the issues of the logistics and trying to keep track of who's had what. So that's all TBD.
And I think one thing too that Dr. Rimoin's brought up is the fact that we do see these breakthrough infections. Our ideal vaccine would be obviously 100% effective and against not only severe disease and death, but against transmission as well. So unfortunately, we're losing a little bit of that with the Delta variant. And I think that is another reason why we need to kind of rethink what our goalposts are here, because the idea of achieving true community immunity, or herd immunity as the epidemiologic term is, defined as going to 0 cases, is probably now going to be out the window with the fact that we have these breakthrough infections with this vaccine. So to realize that you still could get transmission occurring, even though it's low levels, even if you're protecting against severe disease and death. But I think we have to be realization that we are dealing with a very elusive virus here. It's trying its best to evade us, and it looks like it's doing a pretty good job now for breakthrough infection, which actually probably, again, thwarts to some extent our achievement of true herd immunity or community immunity.
Mhm.
I think it's hard to achieve herd immunity when we're not going to get sterilizing immunity from these vaccines.
Yep.
Right. There's an audience question. Should I get my yearly flu vaccine at the same time that I get a COVID-19 booster, if available?
Yes, is the the bottom line answer. So we can avoid the twindemics of both COVID and flu. So it's a good reminder. I'm glad the audience asked that question. We need to make sure that we keep our guard up for influenza as well. We don't need hospitals filled with COVID and influenza at the same time. There was at one time a concern, and that they had actually recommended a 14-day separation between COVID and other vaccines. That has now been found not to be necessary. And so COVID can be taken at the same time as another vaccine, including influenza vaccine.
Great. So looking ahead now, where are we going to be next year? Well, let's not even think about next year. I'm sure people are beginning to think about their holidays, and the holidays are coming up. Today, should people be making plans to travel for the holidays? What's your take on the short term, say the holiday season, and where we'll be a year from now? Anne, I'll start with you on that one.
Well, I think that it all depends upon your risk threshold, your personal health status, the health status of the people around you. Do you have young children who've not yet had a chance to be immunized? Are you around people who haven't had the chance to be immunized? What the community transmission rate is where you're going. I think that there's so many variables. I think that all of us are going to have to be really thinking about risk and our risk threshold going forward to be able to exist. I think there are some risks that are acceptable if you're healthy, if you're young, if you don't necessarily have people around you that are going to be at risk should you get infected. But again, we live in a global community, and we all have to be very thoughtful and not be selfish when it comes to making sure that we're not being part of transmission chains. So, it's one of these questions that is more philosophical as opposed to epidemiological, and I think that really and truly that this issue of risk threshold, but with better availability of testing, getting rapid tests into the hands of people so that they can make decisions, so that they can really check where they are, other things.
And some of these antigen tests that are being used widely in other countries, would you
Yes.
recommend them home antigen tests and so forth?
I think that is going to be the future. I think that we have to be very carefully considering how we are going to bring testing to households, to the individual, at a, not have it just be something that you have to go to a testing center, which makes it very difficult for people to do. I think that there are a lot of rapid antigen tests that, while they may not be as sensitive as what our gold standard is of PCR, it's really okay for a variety of settings. And you have to think about the sensitivity of the testing system as opposed to just the individual test. And I think that that's kind of where we're getting right now. I think that being able to, especially with these more contagious variants where you're shedding a lot more virus, these antigen tests are probably a lot better than they were. There are other technologies like these LAMP assays that are coming to bear, which will also be readily available to people in households, will become important. And I think as soon as we can get these into people's hands, we'll do better. And that's important not only for COVID-19, but I think for preventing the next pandemic before it starts. We all have to get comfortable with this idea of being able to access testing locally and being able to make decisions based on it.
Bob, did you want to venture any predictions or holiday planning and so forth?
Sure. Well, I think Dr. Rimoin's correct in the sense that we all have to realize where are we personally on the spectrum of risk tolerance. And some people do rock climbing on face of Half Dome in Yosemite's, but I mean that's not for everybody. And I think again you have to decide where you are in this risk tolerance, and especially looking individual factors of, again, yourself, your own medical condition, and those around you. I think in terms of the holiday, I think we already are going to be seeing in 2 more weeks the results of what we just had over Memorial Day weekend here. I don't know if I'm sure all the audience, saw the pictures of twice as many people flying as last year, and the big crowds at in stadiums and sporting events, unmasked individuals. So I'm sure that we will have seen and will find a number of super spreader events that occurred here. I anticipate that we may very well see a bump, and I think that can very well get replicated again as we move into Thanksgiving, and just like we had last year with Hanukkah and Christmas and New Year's. Fortunately, we're never going to probably see quite the same as what we were just seeing now in the fourth wave here, or certainly the tsunami that was happening after the last set of holidays, just because we are seeing now so many more people vaccinated and so many people who weren't vaccinated, but were still out and about having some degree of natural infection due to having, gotten the disease, whether they were symptomatic or not. So I think that we are seeing a diminishing number of susceptibles for at least severe disease and death. So I just think that from the individual level, I would just encourage people to try to be somewhat still vigilant, probably to avoid, again, highly dense indoor crowds where people aren't wearing masks. That just isn't very conducive at all.
Bob, that there's an audience question that fits exactly with what you're saying. It asks, it says the 6-foot physical distancing requirement doesn't seem to be emphasized as much anymore. Is it still important?
I think it's still important. Again, from your own personal viewpoint, maybe they haven't imposed those on indoor settings with indoor restrictions. I think because of the just concerns again about what that impact on the economy would be. But I think certainly from a personal point of view, I always try to, again, give myself, even though vaccinated, a reasonable distance from someone else. I just don't see any reason to go into a crowded setting. When we go to a restaurant, for example, and I do go to restaurants, if they have an outdoor seating, I'll take that preferentially to indoor seating. If the indoor seating is such that there is good spacing from table to table, I will go ahead and patronize that. But if I saw that there's no outdoor seating and I looked inside and it's just, chock-a-block with folks, many without masks on because they're eating and drinking, I probably would not eat at that venue.
Well, that was actually the next audience question, and maybe I'll pose this one to Anne. Do you go to a restaurant? Would you go to a restaurant and eat indoors?
No, I would not. I don't think that that's a risk that's necessary to be taking. And I think that we have to go back. This is like, again, what's your risk tolerance? What are you willing to do? Who are you around? What's your risk threshold? Where do you want to sit in terms of being part of potential transmission chain? What's your obligation to society? What's your obligation, globally? I think here in Los Angeles, this goes back to what I said before, that, Dr. Claire Dilleveau, who was one of our wonderful graduates who's now at the Department of Health, said to me very early on, listen, during the 1918 pandemic, we had schools outdoors, and that has resonated with me. Very, very strongly. But I think that that's really true here for California. If places like in California where we live, if we can reduce risk by really promoting outdoor dining, things that are really, much safer, and we can reduce those risks, I think that that's really great. I think it's also, I look for restaurants to go to that require proof of vaccination or a negative test, that are well spaced outdoors. I still think that being in close proximity to other people, even outdoors with a lot of different people, I'm still not really ready for that. I'm a little bit more risk averse and try to set an example. And so I think that for those, it really depends. But I do think by and large, outdoor activities are so much safer than indoor activities. And we have this great luxury of weather in California. We should all be taking advantage of it. And really that will help reduce rates of transmission here. And what we do here has an impact everywhere. Fewer cases here means fewer cases everywhere too.
Yeah. And I think also, to being aware of what is the rate of transmission in the local community that you're in. When you're in a situation where there's high levels of transmission going on, that indoor setting becomes just exponentially higher risk as compared if you have very low levels of circulation of disease going on. It's kind of like being going if there was raining outside, if it's pouring down rain, you're going to get wet. You know, if there's a few drops here and there, the chances are likely you're not going to get wet. So just kind of keep the local transmission rate in mind when you're also factoring in which things you feel comfortable in doing.
I couldn't agree more. It is not a one size fits all. And a lot of the guidelines that we develop or look at depend so much on what's going on in the local community, the local level of infection is. There are a couple of other audience questions that came in. One is about the aerosol nature of COVID, that we didn't quite fully understand it initially. You know, what were the barriers to understanding how it spread and the aerosol nature, and would that have changed things? Bob, do you want to venture that? Or
so yeah, so I mean, I think at the beginning we had much more feeling that this was something that was droplet spread. And of course, droplets are, you know, larger particles. They usually fall to the ground within a meter, 3 feet. We had a little 6 foot distance for a little extra margin of error there. But as we saw that transmissions, you know, were higher than expected, and realized, and was as environmental scientists, you know, worked on this, started looking at some of the tests and things, they realized that there is an aerosol nature, which are much finer particles that kind of waft on the air and could go much further distances. So I think that's a feature that was not appreciated early on, and maybe also led to some of the ideas of not necessarily masking and things like this, that then changed once we learned the true nature of this transmission. We put a lot of emphasis at the beginning also on, you know, cleaning surfaces and things like this. That probably was overemphasized and found out not to be as significant. So again, it's the changing science around a brand new virus that we have never seen before that I think that it's sometimes causing confusion in the public, because it seems like for some, public health is flip-flopping its recommendations, when in reality, I think we needed to prime the population more toward the idea that this is a new virus. We don't know exactly how it's going to behave. These are the things we do know, and therefore these are the measures we're putting in to prevent it. But that, you know, over time, we anticipate we will know more, and our recommendations may indeed change as they have. I think if we prepared the population for that, there had been more understanding of the flow and nature of science and how we have changing needs and changing methods of control.
I just want to, I mean, I can follow on to that, and I can say, you know, from the very beginning, yeah, I mean, I've spent also my career working on emerging diseases, so I'm used to this idea of emerging science in something that we really know very little about. But I think it's important for people to understand that we're making scientific breakthroughs and discoveries every single day on viruses and conditions and, you know, other scientific phenomena that we've known about, you know, for a very long time. So I just think that there's been an expectation and of, well, you said this today and tomorrow you're saying something that's slightly different. And I think that scientists have become very defensive about this. And so they're less likely to talk about some of the issues that are not completely supported yet, because there is so much confusion as to what's going on. And I think that the issue of scientific communication has become very important in this, and also just reminding people regularly that this is evolving science and that we could learn something new that we didn't understand previously. And I think this issue of aerosols were important. The issue of asymptomatic infections were important. You know, there's so many different things that we've learned over time. But I think that the one thing that I can say that we should have learned by this time is it's easier to stay out of trouble than to get out of trouble. So I think that taking a more conservative approach and really thinking about things like ventilation, about vaccination, about testing, and about all these things, the more data that we have, the better that we're going to be in terms of seeing what's in front of us and what's going to be coming towards us. Situational awareness is critical here. And I think that should be the key lesson here.
Right. Data is our guide. And we don't know everything, certainly in the beginning. You know, our time is coming to a close, and I did have two questions, one for each of you. And Ann, I'd like to start with you. And it really follows on what we were talking about, getting information out and communicating, and how difficult it is. to communicate when we don't know everything and getting out in front of the media. And you've done an incredible job in getting out in the media. And I was wondering if you could say a few words about your experience, working with the media and getting out there and trying to get what we know and explain it in basic terms.
Well, I mean, I had been doing a lot of media work for Ebola and for other things previously. So I had spent some time talking to the media about emerging infections before and about diseases we didn't know enough about. And so I think I was a little bit more comfortable talking about things I didn't quite, we didn't have enough information on. But I think that one of the things that was new in this pandemic is, you get a lot of people who are coming to you and saying, thank you for explaining this to me, but, then also getting a lot of very negative attention, getting threats to myself, to my family, things that were quite frankly scary. And, I think that was very, very difficult for me. I'm very committed to scientific communication and to making sure that people really understand what's going on and to be able to provide this kind of messaging in the most relatable way that I possibly can and still, keep it in the scientific domain. But as you well know, I've had a lot of very, very negative and sometimes scary attention where I had to, ask for help from the university and from, other people who, really, helped me stay safe.
Well, thank you for everything you're doing. And we can't forget all of our public health professionals in dealing with the incredible stress that they're doing as we try to get out there and inform the communities. Bob, speaking about stress, you taught a very popular course at UCLA on happiness. And we all need some happiness right now. I'll tell you, this has been going on a long time. And it's enormously stressful and it's kind of getting old. A lot of happy occasions and events are on hold, have been put off, and we're not sure what we're looking forward to. What's your take on how we navigate this and come through this and create a better quality of lives for ourselves as we deal with, we're not really sure what we're going to be dealing with in the next 6 months and so forth?
Well, thanks for that question. I think that, in the course that I just finished was on happiness in the era of COVID-19. What is it and how do we get it and how do we maintain it? But I think the main thing that I found was a very helpful exercise for students, and I think that we can all benefit from it, is, that it's so easy to find all the things we can't do in this era of COVID, or the disappointments or heartaches that we have had, lost opportunities, lost events, is to switch it around and think, well, what are the things that happened to me that made me happier or were positive in this era of COVID? And when I've tasked the students with that exercise, all of them have been able to come up with something, whether it be, gee, I had to stay home and got to know my parents again, we got to know them again, or my siblings, and I was able to help them out, or gee, I had some extra time on my hands, I learned a new hobby, or there are things that people can find. So if we can turn ourselves to look at that silver lining, even in a bad situation, I think it helps build resilience, and we can find happiness even in times of stress and duress. So that's what I would suggest. And also, I just want to again thank you, Dean Brookmeyer, and especially Dr. Ann Rimoin of I think a very exciting session today. And I really have appreciated the audience questions that have come in, and I think that's helped make it something very relevant and fun to do.
Well,
I could not agree more, Bob. Thank you so much for everything you've done, and Dean Brookmeyer for everything you've done, and for really putting together this really important session. I think that we should be doing these kinds of things regularly.
Well, Bob and Ann, thank you. This was a fantastic discussion. I want to thank you for not only what you do today at our webinar, but everything that you're doing for our school and for our communities to keep us all healthy. Thanks very much. I want to thank our audience for being a part of today's webinar and joining us today. Thank you. And and have a wonderful day, and stay well, everyone.